Good afternoon, everybody. My name is Garrett Schmidt. I'm the managing editor and CEO for VBC Exhibit Hall. And thank you for joining us for today's webinar. For those of our live attendees, we did have a little bit of a technical issue on the front end. So if you're able to join us now, we really appreciate that. And we're going to be sending out the recording afterwards. But I wanted to welcome you to today's webinar by Calcium Health called Solving the VBC Cost Quality Paradox. And I'm really excited to hear about this. I know this is a topic we've all been faced with at different times and have been wondering about, and I think we are in for a really great presentation today. So again, thanks for coming. A few housekeeping items before we get started. Everybody is joined today in attendee only mode, so you don't need to worry about muting your microphone or turning off your camera. We can't see you or hear you, so don't worry about that. Secondly, during the webinar, we want to hear from you. So even though we can't hear you physically, we want to hear your questions. So you'll have the opportunity at any time during the webinar to go ahead and submit your questions on your attendee control module. There's a little questions area there, and you don't need to wait until the Q&A in order to do that. So anytime you want to submit a question, even till the very end when we close out, you can go ahead and submit a question there. And if we don't have time to get to yours today, we're going to make sure to get to you via email afterwards. So please, we want to hear from you. Lastly, the session today is being recorded, so if you have to drop off early or if someone wasn't able to make it, we're going to send the recording out afterwards to everyone who's registered. There will also be a link there where you can download the slides from today's presentation. So I'll be sending that to you today in probably a couple hours after the presentation. So again, thanks for joining us. Without further ado, I wanted to introduce our speaker today, speakers rather. Jordan Dolan, who's the board member at Care Advisors, is going to be actually leading the presentation, but Jen Adamski, who's the director of marketing with Calcium, she's going to do a little bit further introduction of him, and then also is going to be hopping back in to help us out with Q&A. So without further ado, I'm going to turn it over to you, Jen, to give us a little bit of a better introduction.
Great, thanks so much, Garrett, and thank you everyone for joining us this afternoon. Hope you're all situated with lunch, and we'll get ahead. And Jordan, we're very excited to hear from you. For those of you who may not know Jordan, he's a 30-year entrepreneur, spent 20 years supporting startups as a mentor and an investor, a board member, and he's got an entrepreneur's mentality with decades of experience in the healthcare industry, with a great track record of supporting and championing entrepreneurs, and has been a very active member in the Chicago startup community. So serving as director for early stage companies, working with dozens of others. Jordan, we're very pleased that you could join us today, and we're very much looking forward to hearing from you and your expertise.
Well, thanks for having me. I really appreciate the opportunity. And we're talking about patient engagement today. I had actually founded one of the first patient engagement companies and spent 20 years selling into health systems and ACOs. So I've got sort of an insider's perspective on the role of engagement and the importance of it in terms of supporting ACOs. So, and as Garrett had mentioned, please feel free to chime in with questions. And I'm not looking at the chat box on my screen, but Jen, if a question comes in, please feel free to interrupt me. I encourage it. So I'm starting off by telling you stuff you already know, but the US healthcare system is a mess. And I was told this when I was in graduate school, that if you start a pitch by telling people things they already know, you seem smart. So I'm trying to tee that up. So the US healthcare system is a mess on so many levels, and you probably already know this, but we spend twice as much per capita as the next westernized or advanced economy. Our admin costs are 3 times higher than the next closest advanced economy, and that's Germany. So we're inefficient, ineffective, our quality scores are subpar, and we have the highest percentage of adults with chronic conditions, the lowest percentage of people who utilize wellness and preventative care, and the only area we score #1 is for adult obesity. So it's not a great situation, and it's also completely unsustainable because, as you well know, those of you in ACOs, we've got a small percentage of the population accounting for the majority of the cost. So you've got fewer and fewer people consuming more and more resources. And the problem is, if you've all probably seen that funnel where you've got of your entire population, you've got your healthy, your pre-chronic condition, and then those with chronic conditions. As you sort of move down that funnel, you're consuming more and more resources. But the only way to fix this is by focusing on wellness and preventative care. And yet there's no resources available because they're all being consumed by the people who are already sick. So it's like a catch-22 in that, you know, there's a problem, and it on its surface it seems nearly impossible to fix. And I'm not sure how many of you have heard this from Epic, but I always have to add in, no, the solution won't be in Epic's next release. And I say that half jokingly, half tongue in cheek, but as a 20-year person running a patient engagement company and now working with dozens and dozens of other early stage companies, Epic is always claiming they've got the fix. Whatever it is you need, they've got it coming in the next release. I can promise you they don't. And I told my family that when I sold Emmy, there were two things I got to do, which was not worry about my kids going to college, and the second was not having to pretend that I respected Judy Faulkner at Epic. So we know how we got here, and it seems like an impossible situation. But I really like how, instead of saying we as the healthcare industry have to accomplish the impossible, let's just give it a name. Let's call it value-based care. So there's lots of permutations, whether it's ACO, at risk, shared savings, value-based care. It's all the same thing. And when I say it's akin to doing the impossible, because how can you improve quality and reduce cost? Oof, somebody there in the background? Hello? I don't know what that noise is. Anyway, sorry, hopefully you can all still hear me. Can somebody mute their phone? Anybody else hearing that?
Garrett, I don't know if you're able to mute other
Yeah, I'll
presenters.
mute everybody. Sorry, guys. Go ahead.
Okay, sorry about that. Okay, so, improving quality and reducing costs seems impossible, but really it's the only viable option for fixing the broken healthcare system. So there's not really any point in debating, how did we get here, the misaligned financial incentives, all of those things. And, everyone's got their opinion on it. But at the end of the day, we've been incenting the wrong behaviors for a long, long time. And the only way to get out of the hole that we're in is that we need to reverse the problems that got us here in the first place. So instead of waiting to spend money on the sickest patients, we need to focus on wellness and prevention. And again, I'm obviously preaching to the choir here because this is an ACO audience. So you understand the importance of preventative care, value-based care, all of these things. And I agree, it is the only way to fix the system. However, it's also very overly optimistic because every single version of value-based care, shared savings, all of these things come down to the fact that they don't work without patients being active participants in the process. And I'm sure you've all heard the quotes. We used to lead our pitches at Emmy by saying, and I forgot who said it the first time, but it's true, patients are the most underutilized resource in healthcare. They can be engaged and they want to be engaged, but it has to be on their own terms. And the point of saying this is that none of these models are going to work without patient engagement. Without the patient playing an active role, all of this stuff breaks down. And hopefully nobody disagrees with me. That's a closely held belief of mine, and I don't see how to get around it. But I also think this is important, and I love adding quotes into my presentations because I don't want it to seem like I'm just talking here and these are just my opinions. Most everything that you're seeing here is based on, studies I've read, research. These are not just opinions, these are things that people have demonstrated. But I also think it's important to note that um, simply becoming an ACO doesn't change behavior. That is, an ACO is simply being on the hook for outcomes and philosophically aligning the rewards with the behaviors you want to drive. But patient engagement has to be part of an ACO, but it's a separate and distinct activity. And I firmly believe one can't exist without the other, but it's important to point that out. And this is my one slide that demonstrates why ACOs are so important and why I believe that it's the only way to fix these things. These individuals actually have these conditions. So think about somebody with prediabetes and somebody with actual diabetes and what it would take in terms of cost and time and effort to change their behaviors. And I used to say to people when I was at Emmy, when I was explaining the importance of engagement, and I would say, how many of you have a grandparent or a parent, depending on your age, who's old and cranky and drinks too much and smokes and swears in front of your kids? And everybody would say, oh yeah, that's my grandfather or whatever. That person changing their behaviors is going to be nearly impossible. However, if you go upstream, somebody who's maybe a little bit overweight, their doctor can encourage them to eat better, exercise. Little steps can have a huge impact. So to me, what's really important about value-based care is the timing, starting earlier where you can have a much larger impact with much less effort. So, and Jen, I'm going to just keep asking you, if anybody's chimed in with a question, please stop me.
Definitely. We did have one that I think might fit towards the end, but it was around just summarizing best practices about payer attribution challenges. I'll just read it off, and if we want to tackle it as we go, feel
Sure.
free to. We have many high-cost patients that are attributed to us by the payers because patient selected the provider. However, when unable to contact the patient does not use our system for services utilization, and the payer is not able to reattribute without patient consent. Our VB contracts suffer greatly in cost and quality.
Yeah, I mean that. So there's a couple of ways you can look at that. It is hard to change a patient's behavior if the patient is not in contact with you or hasn't acknowledged that you're playing that role. The best thing I can say is that effective patient engagement, and I'll touch upon this more in a bit, it really extends the limited resources of providers. So it allows you to have more touch points with a broader audience, and it frees up your resources to be in contact with the individuals who need it most. So, take, for example, engagement for post-discharge patients. Let's just say you've had a knee replacement and you're trying to check in on post-op patients to make sure, who's got an infection, who's doing okay, who reminders for your follow-up visit. Probably 50% of patients don't have an infection, don't have any problems, have made their follow-up appointment, but you don't know that until you call them. So let's just say a discharge nurse has 100 patients per day they want to check in on, and he or she can only call maybe 50 patients per day. Well, if you're using an engagement platform and you've got some feedback from those individuals in advance, you may know 50, 60% may have already responded to you saying, yeah, my surgical site is fine, I've got my appointment booked, so on and so forth. So suddenly you know where to allocate your resources. So instead of spending your time calling somebody who didn't need to be called, you've now got the bandwidth to focus on the people who need it most. Now, again, if they're not answering their phone, if they're not, responsive, nothing is going to change that. But eventually, as as the younger patients age, technology is just a part of their lives. So I just turned 60. I communicate with my doctor electronically, all of those things. So, I mean, that's sort of a non-answer answer, beyond the fact that, like, well, it's super unfortunate, but there is a certain segment of the population that none of this stuff's going to work for, and that unfortunately that segment will shrink and shrink over time. But there's certain things no amount of technology can fix. Hopefully that was sort of an answer. So I'm going to use hypertension as an example here. So you've got all these advances in medicine, hypertension, the high blood pressure. This has been being treated in patients for over 100 years overall, and for 50 years has been effective medication. So it's a very common and costly condition. And with all the advances in medicine, how is it possible that the number of cases is growing? And it's not just that the overall case load is growing, the number of patients, the age of the patients who are getting it is getting younger and younger. So we're getting sicker and sicker earlier and earlier. And half of the US adult population has high blood pressure, and only a quarter of them have it controlled. So medication is readily available, treatments are well known. It's costing $50 billion a year. That's in direct medical costs. How is it possible? And well, the reason is the problem is not clinical. It's a compliance problem. The knowledge is there how to treat high blood pressure, and you can swap out any disease you want: asthma, diabetes, hypertension, COPD. The treatments aren't complicated. The compliance is the problem. That is really what this comes down to. And if you boil it all down, what it really what the root cause is that we know what to do but can't afford to do it. And by we, I don't mean me, I mean the healthcare industry. That is primary care docs, who are the ones most responsible for your overall health. They're overworked and undercompensated. And I don't know if we've got any MDs on the phone. Something I've said since my earliest days in healthcare is that teachers and primary care physicians are the two most underpaid people in the US. So here's just a great example, sticking with hypertension. So let's just say a primary care doc has 2,000 patients. 1,000 of them are hypertensive. Only 25% have it controlled. So that means the other 750 patients need additional support, reminders, encouragement, check-ins, all of that. So take a typical physician group of 3,000 with 4 providers, each with 2,000 patients. You've got 3,000 patients who need additional support. Now let's just pretend that you're going to spend 1 minute per week per patient. That would be an extremely short phone call. Are you taking your medicine? Are you exercising? Whatever. So 1 minute of touch per patient per week, that's 2,600 additional hours. So you're talking about 1.5 additional FTEs for a single chronic condition. And there are quite a few. So a 4-physician practice can't afford to spend an extra $100,000 to check in with their hypertensive patients. It is a non-starter. The result is that you simply have to find tools that can support the care process. So again, I don't even remember where I got this quote from, but it said, transformation within healthcare, meaning bending the cost curve or providing high value healthcare, simply cannot happen without patients taking an active role. They can't, they have to be part of it. And as bad as it is now, it's about to get a whole lot worse. So, and again, most of you on the phone may already know this, but the more often you see the doctor, the healthier you are. So this is just a chart of per capita visits by country, and these are primarily westernized nations. So you can look at Korea and Japan have over a dozen annual visits each to the doctor per person. And as you get down to the US, you can see we're almost at the very bottom. Now, the little stars there, those denote the 10 healthiest countries on earth by overall metrics, overall, health of the population, cost of care. So the whole point of ACOs and population health is more frequent visits for less severe reasons. You come in and get a colonoscopy as required, you get your flu shot, you get all of these things instead of ending up in the hospital for going into a diabetic coma or having a heart attack or who knows what else. So more touches equal better health care. And since doctors are already overworked, the only option is to leverage technology to engage patients. So the most important thing that I want to stress here is that patient engagement is actually affordable, it's very efficient, and it's very effective. The issue is that not everything people call engagement is actually engagement. And affordable doesn't mean that it's free. And the way I explain that is, you could buy a car for $2,000. Car runs, it starts, it stops, it drives. But a $2,000 car might not be the right vehicle to take a road trip from New York to Los Angeles in. You very well might break down, get stuck in a hotel. And my point is there's a huge difference between cost and value, or price and value. Patient engagement isn't free, and it may not even be inexpensive, but it's got a tremendous ROI and is well worth investing in. But you got to make sure you're doing it right. So this is probably the most important point I'm going to make here, and that is, if patient engagement is done correctly, there is a huge and easy to measure impact. And credible vendors, credible resources will happily provide the impact that they're, demonstrate the impact. And there's lots of ways to look at that. There's a wonderful tool called PAM, which is the Patient Activation Measure. And that shows how engaged the people are, meaning how likely they are to take an active role in their care. And that isn't always about how many touches. It could be how many touches they have, but that's not necessary. It could be fewer touches that are highly engaging get you to the same result. It's what does it take to actually modify behaviors? And there's tons and tons of studies. ME Solutions, my former company, we were founded on the premise of engaging patients to drive outcomes, to drive results. So we conducted more than 200 formal studies. We had a lot of anecdotal studies. We probably measured the impact of our platform 400 or 500 different times. 200 were formal, scored, not always published, but peer reviewed, not in medical journals, but I'm getting the nomenclature wrong, had N and P values that demonstrated 99.9% efficacy. So, and when I say there's a broad range of results that have been measured and documented, this is ME and others. These are some that we did, and that is compliance with physician instructions, medication adherence. As you all know, I think initial fill rates of medications are maybe 50, 60%, and then refill rates drop down from there. Engaged patients, you are far more likely to schedule appointments, show up on time, and there's a lot of reasons people don't show up for screenings, and good engagement vendors overcome that. And one example was colonoscopies. We did a lot of work in that area. Non-clients of ours had about a 50% show up rate for people who'd scheduled a colonoscopy. When we started working with various systems, that went up to about 80%. And the reason was we were addressing patients' concerns. We did focus groups. Why did you schedule a colonoscopy and not show up? And the single biggest reason was people didn't understand that you're under anesthesia. You're not going to feel a thing. You won't even remember that it happened. They assume they're going in and this procedure is going to happen and they're wide awake, enjoying the whole experience. So when you answer patients' questions, you alleviate their concerns, their anxieties, compliance goes up. We were able to demonstrate A1C scores being lowered, so diabetic compliance over time. People with asthma, better controlled asthma. And again, you get the idea here. These were studies that we did. But again, like I said, I like to show other people's results. So Robert Wood Johnson has done multiple studies on patient engagement, and patients who have low PAM scores, meaning they're not engaged, have 20% higher healthcare costs. That same patient population are readmitted to the hospital almost twice as often. Med adherence has been measured by the American Board of Internal Medicine. There's a bipartisan policy committee on healthcare technology, and they show that engaged patients, actually have behavior change that is sustained over time. So no matter how you look at this, there's lots and lots of data showing engagement can work and it does work. But if somebody's not showing you results or demonstrating that they can do it, I wouldn't bother. And above and beyond the behavior change and all of that, it's extending your limited resources. So as I had said earlier, it can serve reminders for things like medications, upcoming appointments. You need to schedule. You can provide effective patient education on all different topics. How much should I work out? What should I eat? You can answer FAQs. I recently read that clinicians spend 11% of their working hours on the phone answering patient questions. 80% of those questions are repetitive in nature. I mentioned the Emmy studies on colonoscopy. We found that 80% of first-time colonoscopy patients called their physician's office to ask, how will they know if the PrEP medication is working? And if you've ever had a colonoscopy, you would realize it's sort of a self-answering question. You just know. And yet they're spending tons of time answering those questions. In addition, you can get patient-reported outcomes. You can collect information from patients that you're not going to get otherwise. You can connect patients to other resources they need. Mental health. You can motivate them with gamification and challenges. And again, all of you are ACO execs, so you probably know this. 50% of adults have untreated or uncontrolled mental or behavioral issues, primarily anxiety and depression. If you've got either of those and a chronic condition, your cost of care will increase threefold. So you can do screenings for anxiety and depression. You can connect people with online resources, telehealth, on and on. It makes perfect sense.
Jordan, we had one question that might align with what you're speaking to as far as engagement.
Yep.
One question from the audience was for many ACOs, the challenge is to get the patients on the periphery, that 10 to 20% who won't engage, to begin to engage meaningfully. How does your approach help with those folks?
Well, I mean, it's I don't want to call it my approach. I'm sort of saying the effective approach is that, and this is a perfect segue into what I'm about to discuss. Patients do want to be engaged, but they want to be engaged on their own terms and on their own devices. So I'll give you a great example. I have had like chronic postnasal drip. So my wife said to me, you need to go and see an ENT. I'm like, okay. I called my primary care doc. I said, can you send me a referral to an ENT? She said, absolutely. I'm in Chicago. My doctor is at Northwestern. It's the biggest health system in the city, not in the state. That's Advocate, but it's, dominates the city of Chicago. So my doctor is in Epic, my chart. I schedule through that. Before my ENT visit, they send me a 10-page questionnaire fill this out. And they ask for my health history, my medications, all this stuff, and I fill it out on paper. And at the end, I wrote, why can't you just look this up in my chart? So I get to the doctor's office, I sit down, they tell me to get there half an hour early so they can check my insurance, which is already in their system, and they give me the same 10-page thing to fill out. And I walked up to the counter and I said, you know, I filled this out online, it's already in my health record, and you want me to fill it out again? And, you know, I felt bad for the person behind the counter. They're like, I don't know. I'm just doing what I'm told. So, you know, it's ridiculous and it's frustrating. So how are you going to engage patients when you frustrate them? And this is supposed to be, you know, Chicago's most advanced system. So then she diagnosed me with some type of reflux that causes postnasal drip. And what they gave me was a Xerox piece of paper, a one-sided black and white Xerox that was like cockeyed on the page. It looked like what I got in 3rd grade from a mimeograph machine. So yeah, patients want to be engaged, but this goes back to when I said, just because somebody calls it engagement, it's not. You know, there's lots of little trifold brochures that they have at Walgreens. I've never taken one, but Crames and Staywell, the company that makes those, say this is, advanced patient engagement. So, you know, make it easy for the patient. So when the clinicians are saying, I engage my patients, I allow them to download the portal app and log in using a 29-digit alphanumeric password that they have to change every 3 days. Like, that's not engagement. So I think that the first starting point would be interact with these people the way they're used to interacting in the rest of their life. You know, if you want to book an airline ticket, you can go online, you can call the airline, you can go on the app or to their website. And then the day before, they send you a note, hey, why don't you check in now? If your gate changes, they send you a text. None of that happens in healthcare. And one of the jokes I used to tell when I would lecture a lot on this was that if terrorists really wanted to bring America to its knees, all they would need to do is install an EMR at the airport. So, you know, you check in and you're checking in on Epic, but they print out your ticket in Cerner and the two don't talk to each other. But then your boarding pass that you're going to scan is all scripts. And it's a complete mess. People, you'd stop traveling. It's too frustrating. So I think that's really how you need to do it, is engage patients like they're engaged in every other aspect of their life. And, you know, that's a perfect segue into this. The big elephant in the room is everyone saying, okay, well, we already have a patient portal for engagement. And I hate to burst anyone's bubble, but patient portals do not engage patients. They are very valuable for scheduling, for convenience, for asking questions, but they are not an engagement platform. I have looked and looked and looked, and I'm not going to say it doesn't exist, but over years of looking, I have never found a single study that correlates patient engagement, or I'm sorry, that correlates patient portals changing behaviors and driving outcomes. So, you know, that I don't know what else to say about that. And I feel bad for people who've invested a lot in patient portals, but at the end of the day, EMR vendors are not on the hook for changing outcomes, whereas ACOs are. So you kind of got to go with the data. And to put it in perspective, EMRs were designed to support health systems and clinicians. They were never designed to engage, encounter, interact with, or support patients in any way, shape, or form. They're not intuitive, they're not user-friendly, and they're horribly designed. So, you know, if you look at overall adoption, it's almost non-existent compared to mHealth. And I actually have a stat here. I forgot who did this study, but patients, 60% of all patients, this is for I think 2020, believe they were or recall being offered access to a portal. 60% of total patients. 20%, or a third of that number, ignored it entirely. A third of that number signed in once or twice, and 20% are considered active users. Now, by EMR standards, they define an active user as somebody who accesses their portal 3 times a year, every 4 months. So the patients who do use their portals use it for appointments and refills. So there are, in all of the US, according to this study, the net is that there are 15 million patients who access their portal 3 or more times per year. And generally, those people are the healthiest, most compliant patient. Now, compare that to, and this may have changed in the last few months, Facebook has 214 million users in the US, and 85% access it every single day. So, a high utilizer on Facebook is daily, and a high utilizer on a patient portal is every 4 months. And, also realize that EMRs, our doctors don't even like them, and they're forced to use them. And I would encourage you, if you're a fan of EMR bashing, which I am, the Mayo Clinic did a great study about EMR usability, and out of 100 points, 100 possible percent score, the average of all EMRs across all scores in a meta study had a approval rating of 9%. That's 9% out of 100. So doctors don't like these. Why would they think a patient would? Jen, am I still good on questions, time, everything?
Looking good so far. We have a couple of questions. I might chat with those towards the end. Actually, we did have one from Jose. Thanks, Jose. If patients seen by the PCP before the referral to specialist, is it better than just a referral referral PT to other physician? PCP doesn't want to see patients because the majority are in an HMO.
Wait, read that again.
So if patient is seen by the PCP before a referral to specialist, is it better than just referring patient to another physician? Hopefully, Jose, I'm getting that. The PCP does not want to see patients because the majority are in an HMO.
That's really a payer mix kind of question that I don't think I'm suited to answer. What I will say is that whether it's tomorrow, the next day, next year, ultimately, all healthcare is going to be under some type of value-based agreement. And it's not easy to move that way. The problem is you've got the highest compensated people in a health system driving most of the problem. I have read that up to 50% of surgery for low back pain is unnecessary, and it's extremely expensive. So surgeons drive 80% of the revenue into health systems. And in Cook County, an orthopedic surgeon makes a couple of $1 million a year, and a primary care doc makes $175,000. So, and it's the $175,000 primary care doc who ultimately can change behaviors. So ultimately, it's all going to be under some type of value-based contract. So I can't really answer that question, but I can tell you it absolutely has to change because the economics don't work. And if you really want to drive that point home, most large health systems now have some form of ACO or value-based contract. Some percentage of their patients they're at risk for. And nearly every one of those health systems has 2 individuals in that system, if not more, whose bonus is tied to the same metric going in different directions. So the head of orthopedic surgery, the chair of that department, is compensated on increasing the volume of orthopedic surgeries. And yet the person running the ACO is compensated based on avoiding surgeries wherever possible. So, if that doesn't show the insanity of the US health system, I don't know what does, but the economics have to change. Again, I hope my non-answer was sort of an answer. So going back to engagement, It's complicated. This is a new science. So there's patient engagement and patient education are vastly different things. I've been doing this well over 20 years, and it isn't easy, but you can achieve results. You know, patient education is passive. You read it, it's meant to impart some information. It is not designed to engage or drive behavior. So patient engagement is a purpose-built solution designed to drive outcomes, change behaviors. And you have to take a lot of things into consideration: health literacy, frequency of communication, ability to engage across multiple modality, how often you do it, um, being able to provide that information during a teachable moment. And I'll go back to air travel. It's got to be on your devices, on your own terms. Um, Otherwise, it won't work. And I know Calcium Health is going to talk about what they do, but one of the primary benefits is that it is at your fingertips. It is on your own device. And that's very different than the idea of a patient portal. Nobody, and I'll put it out to the audience here, something like 80% of Americans have a health app on their phone. I have a couple. I track my steps, I track my exercise, I go to Orange Theory. I've never once loaded any of my health information up into my portal. And, people aren't doing that. If you've got an Apple Watch, you're collecting all sorts of information, but 99% of people aren't going to put their daily blood pressure up into their portal. It just doesn't work. So that's what I mean by engaging patients on their own terms. So, once hopefully I've done a decent job of explaining the need for engagement, but here's where I want to talk about that it has to be consumer centric. So, think about EMRs and patient portals. Those are designed to be at the convenience and to support the provider. Healthcare is a business, and it's a service business. You have to cater to people on their terms. Couple of great stats I came across recently, and that is 1 out of 5 patients have left their physician because the wait times were too long. 1 in 3 patients reports having walked out of an appointment because they waited for too long. And, it's a problem. And I can't speak to what the cause is, but you can keep people in the loop. The airline will tell you if your flight's delayed. The doctor should tell you if they're running behind before you get there an hour early. So when you're thinking about an engagement platform and all these tools, think beyond just the obvious of, oh, we've got to improve quality, reduce cost. Where is care going? Obviously, the focus is on wellness, prevention, moving upstream. So portals are something you use when you're sick, when you need to get to your doctor. mHealth apps and these devices, whether it's a step tracker or an exercise thing or the ring that measures your blood pressure, all this stuff, the tools and devices, they're focused on wellness and prevention. They're also collecting a ton of information that can be easily uploaded, and patients are happy to do it. And when I am talking about the importance of patient-reported outcomes, picture a patient has just had a knee replacement, and you want to know if the patient is complying with are they moving around? Are they walking 1,000 steps a day to get their hip or knee broken in and the blood flow? Well, with one of these health apps, the doctor can look online and say, oh yeah, I can tell the patient is up and walking around. They had 1,200 steps yesterday. These apps integrate into everything. So as care moves outside the 4 walls, you have to think about what's the one thing that patients have with them all the time. It's their device, it's their phone, it's their iPad. On top of that, you can roll in all sorts of alternative medications and treatments, which also provide more holistic care. Excuse me. You also have to realize that you've got to think of patients as customers, consumers. Nobody wants to be thought of as a patient. An expectant mom doesn't want to be considered a patient. She wants to be considered a woman who's pregnant. A patient, it conjures up sickness. So think of how people are interacting with technology and then apply that to healthcare. So, as you think about supporting the future and considering the role of mHealth to bend the cost curve, you look at portals. Less than 25% of patients have ever even signed up for one. They're accessed hardly ever, and they're used as a convenience tool for appointments and medications. And they weren't designed for patients. While they can collect and share data with patients, it's not happening. And it's certainly not consumer oriented. So then you look at mHealth. So here, 64% of adults in the US use a healthcare app daily. They access these things constantly. And it's viewed as a platform to support your health, not to support you as a patient. And they were designed bespoke solutions to cater to individuals on a consumer-centric level, and easily can collect and share data. And if you look at the bottom, 71% of patients see the benefits of sharing the data with their clinician, and over 90% are happy to do it. So patients aren't happy to give access to, unfettered access to everything of theirs, but they're happy to upload their data or allow their clinicians to see it, what they're comfortable with. 93% of doctors believe that the data and these tools can improve outcomes. And even hospitals who are, still in the fee for service mindset see that it is much more efficient to use mobile apps and these tools to collect data. So if that wasn't convincing enough, think about this. If you've got high blood pressure, right now the option is, and I've got hypertension, it's controlled, but according to the Epics and Cerners of the world, they think you're going to drive to Walgreens, buy a Bluetooth enabled blood pressure cuff, synchronize it to your laptop, and then try to get it reimbursed from Blue Cross Blue Shield, which, good luck with that. Then you're supposed to measure blood pressure 3 times a day, write it down, log into MyChart and upload it, and do that forever and ever. Or buy the new Apple Watch, and with one button, it measures your blood pressure continuously, and you can set a preference to share your blood pressure ratings with your doctor. What's the reality? Who's going to do what? And there's a fantastic study the University of Michigan did with Apple Watches. They gave them to, I think, 1,000 patients, and over the course of 6 months, they automatically provided hundreds of thousands of blood pressure readings to their doctors, versus the equivalent in a patient portal was like no readings. So it's just so obvious. So before I turn it back over to our hosts, the thoughts I would leave you with is that healthcare is in the age of accountability, and the only 3 things that matters are outcomes, outcomes, and outcomes. Ask for the data, ask for the proof, ask for vendors who will go at risk and, demonstrate that they can do what they say. And, clinical pathways are all evidence-based. Technology in healthcare should be the same. It's criminal to me that everybody uses the term patient engagement, but can provide absolutely no data demonstrating that they've ever actually engaged a patient. So with that, I'm going to turn it back to Jen.
Thanks so much, Jordan. It was a great segue here, I think, to speak to this next slide we've got, just around how calcium really engages with that consumer-centric approach, as you mentioned. The proof is in the pudding, as far as making sure that folks are engaged, that patients are engaged consistently, and not just the one time that they log into Epic to check their records or get their bill is usually what happens. So we have 120,000 users using the calcium app. We've seen the proven results by improving the HbA1c levels, for example, in patients with diabetes. And just sharing here how this data aggregation really helps drive improved outcomes and engage people, and ultimately just resulting in those better health decisions. Thank you for kind of explaining the landscape for all of us, And also, feel free, for those that are interested, we can go to the Q&A slide, Jordan. We'd love to, if you wanted to drop any questions in chat. We did have a couple that we didn't quite get to yet. If we have a little bit of time to touch on those in the final, 8 minutes or so before Garrett kind of winds us up. So I'll give you one or two more questions, Jordan, if you're all right with that. So one of the questions from an ACO was that the big problem we've run into with healthcare tech is that most are created by IT and not by the doctors and nurses actually using them. How do we overcome this issue?
Well, again, you can say who's got results and who doesn't, and that's a great start. I worked in our AI before founding Emmy. I worked in the hardest of hardcore technology. And when I founded Emmy, I used to drag our senior engineers with me out to meetings so that they could actually encounter live human beings and understand what they were doing. So I think that, and again, this comes down to looking at facts and data versus marketing hyperbole. So there are way too many solutions that are out there that are, created by people who don't understand the problem that they're solving. So, I don't want to say buyer beware, but I would say talk to references, look at the product. Do they do focus groups? What is their approach to ongoing refinement of the tool? Ask how did they create their content? So, I always say that patient engagement is really simple. It only needs to do three things, and that is, provide everyone who needs information, support everyone who needs care at every single point in the care continuum. 2, support every single person who provides care across the entire care continuum. And 3, drive results for everyone who's receiving care and providing care. So, there's lots of questions you can ask. How often do you update your content? Show me utilization. How often are your tools being accessed? And if they're unwilling to show it to you or can't show it to you, that's a great indicator that maybe you should keep looking around.
Great advice, Jordan. One more question. How do we get our members to buy into these necessary changes?
I think that is, again, working with better vendors and understanding what really matters to your patients. I've said to my clinician a million times, like, I don't like that I take blood pressure medicine. Like, if there was an app on my phone that said, hey, you need to eat salmon 5 times a week and you need to walk 15,000 steps a day, and it would prompt me and say, if you walk 8,000 more steps today, you may get off your blood pressure meds or something, and that goes back to gamification. What is going to motivate people? Well, ask them what matters to you, set goals, and there's, that's sort of easy to do. I don't not it's easy to set up, and not that it's super easy to get everyone to comply with. But if you say, hey, I take medication for blank, how do I get off of it? It's sort of like when people want to lose weight. Fad diets, fasting, it doesn't work. It's sort of long-term behavioral change, get these things into habits. So if you've got something that is supporting the patient, saying, hey, you're doing well, you're doing this, doing that, that's more likely to get them on the path. And you can't do this with portals. You can do it with these health apps. Let's just say somebody likes to eat healthy and they're a runner and they've got a busy work schedule. Well, wouldn't it be great if your app on your phone said, hey, I can tell by your phone or your Apple Watch, you're in Denver. Do you want to know good running paths near you? Do you want to know restaurants that have healthy food? Again, everyone on the phone is an executive in ACO. You're probably going to lots of conferences and stuff. Your diet and exercise routine go down the toilet when you're traveling for work because you're stressed, not sleeping, having drinks with, clients. So support patients where they want support. Don't just say to the patient, oh, here's a Xerox of the DASH diet. Follow this, measure blood pressure 3 times a day, and call me in 6 months. That doesn't work.
Well said, Jordan. Thank you. I believe we're almost out of time. There were a couple, great questions from the audience. Thanks, everyone. We would love to hear from you if you have further follow-ups. There's some contact info here, and Garrett will kind of wind us down with some other final thoughts.
And Garrett, before you go through that, to follow up on what Jen said, everything in my presentation was based on studies and things that I've collected and found. If you want any of the supporting information, feel free to reach out to Jen and she will pass it along to me. I'm happy to dig that stuff up and provide it because there's so much great information out there that can really help guide these things. It's not as intimidating or difficult as it seems. Just the waters are muddied by people selling marketing, not outcomes.
Mhm.
Thanks again so much, Jordan.
Well said, Jordan, and thank you both for an excellent presentation, Jordan. There's a lot of really great information in here. I look forward to going back through the slides myself. But we are out of time today, so thank you so much for joining us, and I appreciate you guys bearing with us with our technical difficulties early on. And as we conclude, I wanted to encourage you all to visit the Calcium Health exhibit booth at vbcexhibithall.com. Jordan, can I get you to advance this slide forward?
Oh, you bet.
And there you go. So this is what it looks like. If you go to vbcexhibithall.com, Calcium Health actually has an interactive virtual booth there. And that's where you can interact with the team and you can learn more about some of the things that they're doing. And it's a great way to engage with them. And also, this is where the recording is going to be housed in the library of vbcexhibithall.com. If you wanted to get that later on. However, if you are registered, I'm going to send that out to you this afternoon. So I'll be sending out a link to the recording and also where you can download the slides from today's presentation. And then lastly, of course, if you would like to get in touch with any of the speakers or with the Calcium team, please reach out to them directly. If I could get you to advance to that last slide, Jordan, I think we've got our contact information on here again. There we go. And you can reach out to Ray, who's at Calcium Health, and he will be happy to get back in touch with you or put you in touch with whoever you need to be, or you can reach out to me directly, and I'm happy to facilitate an introduction. So
I want to give,
yeah, go ahead, Jordan.
One last word about Calcium Health, and this is going to sound like a commercial, but it's not. So I sold ME Solutions to Wolters Kluwer, I don't know, 4 or 5 years ago. And since then, I work with a lot of startups and I get contacted all the time. I mean, constantly. We started one of the first patient engagement companies. So people are reaching out to me constantly saying, will you meet with us? Will you advise us? Will you do this? Do you do that? 99% of the time I say no, because I feel like nobody understands engagement or is willing to roll up their sleeves and do the hard work. Calcium had reached out to me and I agreed to become a director of the company, join their board. And the reason was, they were the 1 out of 300 because they were actually taking a consumer-centric approach, not just saying it and doing the work. They spent, before I ever met them, a couple of years building a technology platform which actually pulls down all the data from your EMR so that you have it on your device. So again, it sounds like a commercial, but the proof is in the pudding. I turned down hundreds of people asking me to help them. I said yes to these guys, and it was because of the way they approach it. That's showing my belief in consumer-centric engagement.
Well, that is a great testimonial. Thanks for that, Jordan. And yeah, definitely reach out to them if you have any questions. They'll be happy to get with you, or I'll be happy again to facilitate an introduction. Thank you all so much. We know you have a lot vying for your time right now. Appreciate you spending the afternoon with us, and we hope to see you next time. Bye now.
Bye. Thanks, everyone. Cheers.